So rash is certainly a common feature of all of the agents in this class, epidermal growth factor receptors. So we see these epidermal side effects, sometimes hair changes, eye irritation, but rash is really one of the most common of them. And stomatitis to a lesser degree, but something that we need to be mindful of with afatinib, certainly. And with regard to the rash, we start with topical agents. I usually have patients on a topical antibiotic, such as clindamycin gel, and also on a hydrocortisone cream. If it is really only a limited area of skin involved, that is often enough to manage that quite effectively. If it is more significant, I might put them on an oral antibiotic agent like minocycline. We can also consider doing oral steroids. If patients are really needing a lot of support for this, I would really think about a dose reduction. On the other hand, there's some evidence that oftentimes the rash does tend to abate over time. So many times patients are most bothered about 2 or 3 weeks in, but if we can get them through that, they can do a lot better. I think the most important thing is not to throw out the baby with the bathwater. Have patients be prepared that they may have side effects. These are treatments that have adjustable dosing, and that these can be extremely valuable therapies, and we should not give up on them because of potentially some difficult times in the first few weeks, especially when there are so many options for managing that. In terms of the stomatitis, you can do sodium bicarbonate rinses or saltwater rinses, and of course you can also consider a dose reduction if it's really going to be needed.